We're happy to be back this morning on Health Matta on WAP TV. And with me today is Dr. Tosin Majekodumi.
Good morning again. How you doing?
Thank you very much. Thank you for joining us today.
Pleasure.
Of course, he was with us last week for a different topic. But this morning, we'll be looking at yet another new topic. I will be talking about congenital heart disease or congenital heart defect, CHD for short, if you like. What are these all about? Congenital heart disease. Of course, anytime you hear congenital, it has to do with an inborn error. Okay, it has to do with a problem that probably was discovered shortly after birth or in utero while the baby is still within the womb. So congenital has to do with inborn abnormality, okay, that has to do with the heart. And that is what we'll be centering our discussion this morning on. But before we go ahead to talk about that, I'd like to give an overview because this topic may be a little bit complicated, but we'll try and simplify it as much as possible so that everybody out there will be able to pick something from today's presentation. Okay, so I want to give an overview of the heart, what is it all about, the location in the body, the basic anatomical features that we need to know about the heart and structures. Okay, so the heart, as we all know, is a hollow organ that pumps blood. It's a pump that is located within the thoracic cavity. That's the chest area. Okay, if you make a clenched fist, your heart is about the size of your clenched fist and is located on the central part of the chest, but a bit deviated towards the left. Okay, so that's where you have your heart. Now, the heart, as a muscular organ, is also a pump that is responsible for pumping the blood that is distributed to our heads, our hands, and our legs, and all other parts of the body. Okay, so the heart is subdivided into 4 chambers. The bottom chambers are called the ventricles, while the upper chambers are called the atria, one atrium. Now, what happens is that the heart is structured in such a way that the left side of the heart, which is actually this part of the heart that is responsible for pumping blood to all other parts of the body, usually is very, very muscular. Okay, much more muscular than the right ventricle because of the work it does. Okay, so the pictures will be presenting to you to enable you have a clear understanding. You just imagine looking at somebody, the heart that you're looking, or the picture you may be looking at may be that of the person standing before you. So the right side of your body will become the left, while the left will become the right. You can see what we have on the screen at the moment. So you can see the 4 chambers of the heart in that illustrated diagram on your screen at the moment. So you can notice that on the lower side, the left side of the heart, you can see that the ventricle, which is the bottom chamber, has big muscular tissue, okay, because of the degree of work it does. That is why it is structured in that pattern. If you look towards the right ventricle has a somehow shallower muscular wall. Okay, now in between, on the right, you have a septum that separates the left side of the heart from the right side of the heart, and that is called cardiac septum. Okay, so above the left ventricle, you have the left atrium. And this left atrium, usually we drain blood through a valve, okay, into the left ventricle. So what happens is that in circulation, what happens is that you have set of valves that are usually one-way valves. They go one way. The reverse cannot be the case. But when you have abnormalities, that can happen in some situations, which of course we are going to look at later in the program today, because we have with us in the building an interventional cardiologist, an expert in this field of medicine that will be doing justice to all of this. But first, I want to oblige us with the little anatomy that we need to have a grasp of to be able to understand what we're going to talk about. So on the left, there is a valve, usually, that connects the left atrium to the left ventricle. That valve is called mitral valve or bicuspid valve. It usually has 2 cusps that open in one way. Now, when the blood drops into the ventricle, the blood will leave the heart through another valve that is called aortic valve, okay, or semilunar valve. That is the way we were taught in biology in those days. Now, this aortic valve is somehow triangular, so you can see the pattern. The arrow shows how the heart will pump blood away from that aortic valve. And once the heart does the pumping, that blood will escape through the aortic aorta, which is the biggest artery you can see in that picture. Okay, still on the left side of the heart, you have a set of veins. Veins usually brings blood back to the heart, while artery takes away blood from the heart. You have a set of veins. Two are captured in the picture, in the diagram you have before you, but as a matter of fact, you have about 4 veins, set of veins that actually drain blood into the left atrium. When this blood comes to the left atrium, it flows down, that valve opens up, and of course it flows down into the left ventricle, and it is pumped to all other parts of the body, okay, into the systemic circulation. Now what happens is that this blood that is coming from the lungs, the pulmonary veins, will come with blood from their oxygen-rich blood that will be distributed to all other parts of the body. So when the blood is going around to the head, neck, hands and legs and everything, it will get back to the heart again through the left side of the heart. This time around, it will come back through the biggest veins that are found in the human body. Okay, this one is superior, one is inferior. Superior vena cava and inferior vena cava. So the blood will return back to the heart through these major vessels, the veins, and it will pour back into the right atrium, okay, which is actually where the SA node is located. When we talk about the electrical activities of the heart, we'll be able to mention that. So this blood that has returned back to the heart will come with oxygen-low blood. The oxygen that has gone around is not completely used up by the body, so it comes back with some degree of oxygen, and of course it passes through a valve, okay, which is the tricuspid valve, because it has 3 cups. It opens and it enters the right ventricle, and this, from the right ventricle, the blood again will be pumped. This time around, you can see the blue depicted arrows. It will pump and it goes through the pulmonary valve, and then pulmonary has to do with lungs, and of course it will divert to the 2 lungs where it gets to and becomes oxygenated again, and of course returns through the left side of the heart into the left atrium and the left ventricle, and of course another cycle takes place, and this can happen within minutes. Okay, so that's just to give you an idea of what happens. Okay, so we'll see another picture where you have a better illustration of the cardiac muscles, which could be damaged. Okay, the heart is actually surrounded by a thin layer of fibrous tissue that is called the pericardium, and deep within it you have the myocardium, which is the muscular layers of the heart. Okay, and on the muscular layers of the heart you have a number of them. So this is what happens when the heart pumps blood from one region of the body to the other. What may not be depicted in the diagram we are seeing is the electrical activities or conduction of the heart that usually will start from the right atrium with the SA node, and of course the AV node towards the ventricle and all over the body. So this just to give us an overview before I yield the floor finally to the expert we have in the building who will be taking us on this roller coaster experience. Chief, once again, you're welcome.
Thank you very much, and thank you for that fantastic illustration first thing in the morning. Very educational, even for me as well, to be able to listen to the wonderful description. So it's very useful for our audience to have an idea of what the heart looks like, because when we are talking about congenital heart diseases, it may be very helpful for them to understand exactly what defects that we're going to be talking about. And just as you started off explaining, congenital heart disease is something that somebody is born with. It's a problem with the heart. The heart is, for some reason, is not formed properly. And this is actually not that uncommon. 1% of all births will have some form of congenital heart defect. 1%. So if out of every 100 babies that are born every year, 1 of them will have some form of congenital heart defect. It may be a simple heart defect or a complex heart defect, but it happens quite commonly. And in fact, just to help the audience understand a little bit better, if anybody listening, a lady especially, already has a congenital heart defect herself, some form of heart defect that she was born with, that she maybe had an operation in childhood or that she's managing now as an adult, the chances of her having a child who also has a heart defect is higher. So for everybody else, it's 1%, but for her, it's about 5%. So it's not so high, but it's very important to know so that a lady like that, when she has a child, if there's any suspicion, usually a child like that, you should be checking them. You should have a very high index of suspicion that they may have some form of congenital heart defect. Now, when we talk about congenital heart defects, what do we really mean? Just to, again, keep it simple for the audience, keeping in mind the diagram that you so beautifully used to explain everything. The common term that we use is there are holes in the heart. So we say that there may be a hole between the two top chambers of the heart, the two atria, as you described, or a hole between the two bottom chambers, the two ventricles, as you described. There may also be problems with the valves in the heart, either the pulmonary valve, which you talked about, which is where blood leaves the heart to go to the lungs, or the aortic valve, where blood leaves the heart to go to the rest of the body. And the babies are born with this. And I think during our discussion, we'll be able to talk to the audience to let them know what kind of things they should be looking out for in their children that may make them think, hang on, I listened to that talk the other Saturday morning. Has my child got a problem with a hole in the heart or some other problem in the heart that may need them to be assessed?
Thank you very much. Now, for practical purposes, how can a mother that has just delivered a baby, how can such a mother pick out some of these early symptoms in the child? Are there things that we should look out for, or such a mother should look out for in the child, probably when the child is being breastfed or when it's being fed with infant formula or what have you? Are there signs that we should look out for? Absolutely. In a newborn baby?
Absolutely right. So these are the things that we really want to bring to our audience today. So there are definitely things that one can look out for, and sometimes depending on how severe the defect is that the child has will determine the way that somebody may notice that something is wrong. So those children with very severe heart defects, the moment they come out of the mother and they are delivered, people will notice a problem. Usually one of the earliest things that you may see is that the baby looks blue. The lips are very dark. You know, it looks as if they're just not getting enough oxygen in. These are what we call cyanotic heart conditions, where the child does not get enough oxygen to the blood that is going all around the body. And so that may be one of the first things that the mother may see, or even the healthcare givers in the hospital where the child is born may see, is that this child looks very blue. If they notice something like that, they need to get an echocardiogram, a heart scan, ultrasound scan of the heart, and that will usually diagnose 99% of all congenital heart conditions. Other things that they may recognize, just as you alluded to, is when the child is being breastfed. Some children, the mothers will report that they are noticing that the child is breathless while he's being fed, or that he seems to be struggling to breathe while he's being fed. And some of that struggling may result in the child sweating. They may notice the child is sweating a lot while they are being breastfed. And that's because breastfeeding for a baby obviously can be a very difficult thing, because they are trying to suck milk in through the mouth and they're only breathing through the nose. And if they already have a problem with their breathing, or their breathing is compromised, it gets worse when they are being fed, which is why they notice that they have these problems. You may also notice a problem where the child is not gaining weight appropriately after the child is born. Most children, they are born with a normal weight, and then as over the next 4 weeks, 8 weeks, they are growing consistently because they are being fed all the time. But then they may notice that this child is not gaining weight. I'm feeding, I'm trying to feed, but the child is not gaining weight. These are the kinds of things that should prompt either the caregiver, the doctor, midwife, pediatrician to say, something is not right with this child. Could it possibly be that they have a heart condition? And it's one of the things that they should check for. And one of the last thing I'll mention is just sometimes when people are being fed, so when the child is born, the child may look normal, healthy, with pink lips and everything. But when they are being fed, the lips may turn blue. And then the child you may notice that the oxygen levels are going down when they are being fed. That may also be a sign that the child has a congenital heart condition.
Thank you very much. Thank you very much. Now, usually at delivery, oftentimes, of course, when children or babies suffer some degree of birth asphyxia, when they come out, they have some challenges that will make them turn blue at the initial stage. Okay, after a while, after vigorous resuscitation and oxygen supplementation, the child picks up, every place turns blue, turns pink. not blue anymore. But oftentimes, such children, such little babies may become oxygen dependent. We have that situation. Should we be worried, sir?
Yeah. So if you get a situation whereby, so that is why when children are born, they have the midwives and the pediatricians, the attendants, they have a scoring system called an APGAR score, where they look at the child, at 1 minute after the child is delivered and at 5 minutes after the child is delivered. So usually at 1 minute, as you said, the child may be a bit blue because of a bit of asphyxia, a bit of aspiration of some of the contents and things like that. But usually by 5 minutes, a lot of that should have resolved and everything should get better.
So if the child becomes oxygen dependent over a period of, say, 24 hours,
so
48 hours,
clearly,
should we be worried?
Definitely, you should be very worried and should try and get, I mean, it may still be a lung-based issue, for example, maybe secondary to aspiration or whatever, but certainly in that situation, somebody needs to have a look at the heart of the child, because these things are not uncommon. 1% of all births have this problem. So then someone needs to be looking at the heart of the child to make sure that the heart is normal.
Don't forget, we are talking about congenital heart disease or congenital heart defect. And with me in the studio is still Dr. Tosin Majekodumi, the MD of Uracare Multi-Specialist Hospital in VI here in Lagos. My doc, nice to have you once more.
Thanks again.
Yeah, thank you. Shortly before we came on board, you were telling me that you got a call from somebody.
Yes, that's exactly correct. So I was very privileged to be on with you last week.
Thank you.
And last week we were talking about conditions that mainly affect adults, in terms of hypertension and coronary artery disease and heart attacks and such not. When we completed the show and I was actually on my way back to the office, we got a call from a patient who had chest pain and was keen to have it investigated from outside Lagos, I think from Port Harcourt, and he actually came to Lagos as a result of the education we had on the show. He came to the hospital, we checked him out, we checked the blood vessels around his heart. Unfortunately for him, he did have some significant disease in the blood vessels around the heart, but not bad enough to require a stent or bad enough to require surgery. So we were able to reassure him that he wasn't about to imminently have a heart attack or die of a heart attack. We were able to alter his medications to reduce his risk and give him the right advice as much as possible so that he can continue to be as healthy and as active as he wants to be. So I think it's a very, very, I want to really thank the producers of the show.
Thank you very much.
No, it's fantastic.
It's such an inspiring one. It's on that note that I would like to open the phone line so that the viewers at home can have or can make their contributions, should there be any, or probably ask us questions. You may have 1 or 2 little children in your house that have been having some challenges along this line, but you've never really gotten somebody to talk to you about it or what could be responsible. Now you have an expert in the building to answer this and many questions that you may want to ask us today. So, Chief, let me start. At what point during development does the heart start to beat in a child? When do we start having these congenital malformations in utero, inside the womb?
So yeah, you're going back to my embryology. So the heart starts to form, I think usually about 6 weeks of age. Okay. Starts to beat roughly around that time, and then all the different chambers start to form. There are various mechanisms which are very complex and ongoing in terms of looping one way or the other that start to form the valves. Now, the reason why congenital heart defects form is that in that process of the heart forming, something can go wrong. Whether the looping can go wrong, the formation of the walls between the right and the left ventricles, which people are not familiar with, can go wrong, and the walls between the atria can go wrong, etc., etc. So there are so many different types of congenital heart diseases that patients can suffer from, and it is whatever combination of defects that they have that will lead to how they will present, whether they present as a baby, or sometimes, in fact, we get some children present at older ages, 5, 6, 7 years of age, and some people even present as adults. One of the common things that we see in adults are we see middle-aged people, 30, 40, maybe 50 years of age.
Sorry to pause you. We have a caller, our first caller for today from Lagos. Good morning, sir.
Yeah, good morning.
Yeah, how are you today, sir?
I'm fine, sir.
Please go ahead.
Yeah, I want to ask questions. I have one neighbor here. She had a baby, but the baby has heart issue. But unfortunately, the baby is dead now. So I want to know what is the cause of that heart issue in babies, like.
Right. That's
Thank you very much.
Thanks for the call. That's really an unfortunate outcome, and it's one of the reasons we are doing this show today. Is we want people to be able to recognize that there's a possibility that the baby has a heart problem, and that to be also be aware that things can be done to fix such heart problems. In terms of whatever the specific defect this baby had, unfortunately, we don't have those details. But there are so many different types of congenital heart defects that can present in children that can, if not treated quickly, can unfortunately lead to this kind of very sad outcome. And that's why we are really sitting here today, so that people don't delay. People are aware of the kinds of things that should make them think, has this patient got a heart defect? Has this baby got a heart defect? And to know what kind of tests need to be done, and to be aware of the fact that there are solutions. So there are solutions that may require surgery, and the surgery can be very early, at a month of age. There are some even defects that, people have to have surgery at the age of 1 day of life. Day one of life, they need to have surgery. I know people will be very alarmed that it's such a tiny baby, having operations, but sometimes it is necessary. So the real thing I want people who are listening to take away is that there are children can have heart defects. They need to be aware of the things that the symptoms that such babies can have: breathlessness, sweating while feeding, blue lips. If they are slightly older children who normally, how children are 2-3 years of age, they're running around and playing with their friends and things like that. If you notice a child that doesn't seem to be as active, seems to get tired easily, one of the things we talk about is the baby that squats a lot after he has been walking for a while. You notice that he seems to be squatting after he's exercising, or when he says he's tired. Those things should prompt you to go and get a cardiologist, a pediatric cardiologist, to have a look at the child and make a diagnosis of a congenital heart defect or some other hole in the heart. And it's very important that these things are picked up early, because if they are, they can be treated. And if you wait too long sometimes, then you may not be able to treat them anymore.
Mr. Paul, good morning. How are you today?
I'm fine. Good morning.
Good to have you.
So I'm calling from River State.
Okay.
Yes, doctor, thank you for this opportunity. I think I was doing something. Something was just like on your TV, and that's what they were just showing, and something that is giving me serious concern. I'm having issue with my chest, and it started from the left, now moved to the right, now started pinning me at the back, down to my waist. As I'm talking to you, my waist is giving me serious concern. I can't even stand up freely. I have to move to left and right before I can get up. So that is my challenge, and that's the reason why I said that when I saw this program, I said no. I drop whatsoever thing I'm doing, and let me connect and know what.
Yes, please don't drop. Hang on a bit. How old are you, sir?
43 years.
Okay. Do you have hypertension or anything you want to tell us? Do you have any chronic illness at all?
No. Apart from that chest.
Okay. When last did you have your BP checked?
Whenever I went to the clinic, they always check my BP. So roughly a month now.
Okay. What are usually the values
of the BP?
Yes.
Yes. According to the doctor, he said the BP is very okay. He's from Better Clinic.
Okay. Thank you very much.
That is very cool. Yes.
Thank you very much. Chief will reply you now.
Okay, so thanks very much for calling, and I really appreciate your call, because we really want to encourage everybody. Once a man or a woman above the age of 40, you have any chest discomfort, any other chest symptoms, it is very important that gets evaluated, because it could be a risk factor for what we talked about last week in terms of heart attacks and things like that. So what I would urge you to do, please, is if you're having chest discomfort and spreading anywhere, you need to go to a hospital or a clinic where you have a cardiologist. You need to have an ECG. We talked about this last week. Anybody who is having chest discomfort must go to a clinic, and they must do an ECG. Not, we are going to do an ECG, come back in 3 days and do an ECG. Right that moment is when the ECG should be done on the spot. Time. If they say they can't do it, go somewhere that can. But it's very important you get an ECG done on the spot, and someone tells you what it shows. Not, we've done the ECG, but there's nobody to report it. Come back next week and somebody will tell you. That doesn't work. You need someone to tell you right then and there whether there is a problem or there is no problem. So please, I would advise you, if you're having chest pain, chest discomfort, go to the clinic, get an ECG done, and let someone tell you whether there's a problem with it or not, and then you can take it from there.
Thank you very much. You mentioned risk factors along the line. Are there risk factors for the development of congenital heart diseases in children? Okay.
Yes, so I mean, in contrast to the adult diseases we were talking about last week, there are no conventional risk factors that can cause congenital heart diseases in children. As I mentioned earlier in the first segment of the show, they are very common. 1% of all births will have a congenital heart condition. The only risk factor per se will be if there's an adult who already has a congenital heart condition. Okay. Say the mother already has a hole in the heart that was treated when she was a child or something like that. When she has a child, it means that that child is at higher risk of having a heart condition. So normal risk of having a child with a heart defect is 1%. But if you already have a heart defect, the risk of your child having a heart defect is about 5%. So those are so if you know you have it, then that is very important. In developed countries like the UK, the US, they have very sophisticated systems whereby any woman who is pregnant gets a very detailed scan, which includes the scan of the baby's heart, even while the baby is in the mother, usually about 20 weeks gestation, and they can already tell from there whether the baby has a significant heart defect or not.
Thank you very much.
We don't really have that in Nigeria yet, but you know, people just need to be aware of it.
Now, talking about pregnant women, I think we have a caller, Boyemi from Plateau. Good morning.
Yeah, good morning, sir.
Yeah.
Good morning.
Yeah.
Please go ahead with your contribution.
Okay, thank you, doctor. I really appreciate.
Yeah, thank you very much.
So far. And my question only is that sometime, like some 6 months ago, I was having repeated angina, just a sharp pain in the heart. But after a while, I started exercising. But since then, I've not been having it that repeatedly again. Though I didn't consult any doctor, I just started exercising on my own.
So you made the diagnosis by yourself.
How
old are you, my brother?
I'm 30.
Okay.
So from Google search and other things, I just started exercising and the things subsided completely. But after a while, I've been having like once in like 2 or 3 months. I may just have it. It was not that as painful as it used to be. Is the exercise sufficient, or or is there any medication or anything that I need to add, or I should just start exercising?
Thank you very much. I was going to add that the further evaluation should also be done. That ECG that we have been mentioning, you need to have it done. But I'm sure doctor will have 1 or 2 things to tell you.
Yeah. So, I mean, thank you very much for calling, and I really appreciate the fact that we are hopefully getting to a stage where people are getting aware of the fact that if they have chest pain or chest discomfort, you know, it's something to be taken seriously. It has to be said, I've not taken a detailed history from you or examined you, but it sounds like you are 30, you are able to exercise, you are getting symptoms maybe once every 2 or 3 months. This does not sound like the kind of thing that worries me as a cardiologist, that this guy is about to have a heart attack or anything like that. But the only way one can say that for sure is, exactly as doctors said, get an ECG done, see a doctor, and let him just give you that clean bill of health that, look, you are fine, your heart is okay, you can go back to exercising, you know, without any concerns, and just to stay as healthy as possible.
Thank you very much. Now, back to the pregnant women. Are there medical conditions or infections in pregnant women that can predispose their children, or some other factors like taking some set of medication, drugs, infections like rubella, measles? Can they predispose a child to having that?
So these are very
and also things. Lack of folic acid,
yes. So these are all very good points. So I mean, there are some traditional things that we have always been taught can predispose children to heart conditions, particularly in the mother. So if the mother has rubella, as you mentioned, and some other viral illnesses, that those can possibly predispose to the development of congenital heart defects. One of the classic ones they teach us in medical school is taking lithium. If you take lithium, if the mother is on lithium therapy, that can cause certain congenital cardiac defects, and certain drugs as well. If there are other drugs, not just lithium, but other drugs that people take that may predispose to congenital cardiac defects. These are really they do exist, but they are really quite low. I mean, the number of people in Nigeria that get maybe rubella and things like that, I mean, we don't have a lot of data, but it doesn't seem to be a very serious problem. I think the one I would like most of our audience to walk away from.
Some of them are vaccine preventable too.
So, well, exactly. Everybody should be vaccinated by now. The MMR vaccine is widely available, and I think it's part of the normal vaccination schedule that everyone should get them at the appropriate intervals. Certainly by the time that they're an adult. So, the most important one is if you already have a congenital cardiac defect, your child is at higher risk. It's not a very high risk, it's only 5%, but it's important to be aware of it. But it's also just very important to be aware of the symptoms that we talked about, the breathlessness and everything.
Just a minute. James from Lagos. James, good morning.
So, and I don't know the right drugs I will use. Like rashes all over my body.
Okay. How old are you?
Yes, sir.
How old are you, Mr. James?
38.
Okay, you said you have rashes all over your body.
Yeah.
Any other thing apart from that? The rash you have, does it itch?
Yes.
It scratches you?
Yes, sir.
Okay, thank you very much.
All right.
Now, he said he has rash all over his body. Are there cardiac conditions that can give such presentation? Before we go to that one, monkeypox and water.
So I was actually trying to rack my brain about any cardiac conditions that can cause rash. Well, I mean, the only one I can think of that can cause a kind of itching, although I'm not even sure it does, is something we call carcinoid syndrome.
Yes.
Can cause some sort of heart disease, not congenital heart disease, which we were talking about today. We can affect the right-sided heart valves, which your audience are now going to be aware of, and that may sometimes cause itch and things like that, but it's very rare for cardiac conditions to cause a rash. I think he probably needs to see a dermatologist.
Yes, thank you very much. So you need to see a dermatologist, skin doctor. That should be he or she should be able to sort you out. Now, Chief, you talked about types of congenital heart condition. You mentioned acyanotic heart conditions. There should be cyanotic heart conditions. Correct. As well. Do they present differently?
They do. So what we talked about initially, we talked about children having blue lips, or you notice that somebody gets blue lips when they are feeding, or sometimes after they've been exercising. Those conditions are called cyanotic heart conditions. What cyanotic means is that the oxygen amount in the blood is low. The reason why it seems like the oxygen in the blood is low is that in those conditions, there is what we call mixing of blood between the right-hand sided chambers and the left-sided chambers. So if everybody remembers the beautiful lesson you gave earlier and then the illustration we had in the break, there is some sort of hole that allows blood on the right-hand side that has no oxygen in it and blood on the left-hand side, which is supposed to have oxygen in it, to mix together. And this overall brings the saturation in the blood low. So if you imagine that the left-sided blood should be 99% and maybe the right-sided blood is 50%, if you mix the two together, you may end up with an average saturation that ends up going into the body of 70%, and that's why their lips are blue. So those are the cyanotic heart conditions. There are a whole bunch of them. There's tetralogy of Fallot, there's hypoplastic left heart syndrome, there's truncus arteriosus, and a host of others. And then we have the acyanotic heart condition. So there is still a heart defect, but there is no mixing of blood such that the oxygen in the amount of blood is low. And those conditions also exist. Classic ones are pulmonary stenosis, atrial septal defects. These kinds of things can cause, they still have a heart condition. They present differently because now those children or those adults are not blue, but they complain of breathlessness or chest pain when they exercise, and not able to do so many, and get very tired easily and things like that. Again, the good news which I really want to emphasize for the audience is these conditions do exist, but they can be treated.
I do know that some of these congenital heart conditions can actually, some of them may disappear shortly after birth, while some persist, and it's not all of them that should be a source of concern and worry for us.
Absolutely. So there are some peculiarities to what we call the fetal circulation, where blood goes from the right to the left-hand side through a hole that is supposed to be there.
So what you are saying is that the fetal circulation is different from adult circulation?
Absolutely, yes.
Okay,
and it changes the moment the baby is born. So, we have this tradition where the baby is born, and then the first thing you do when the baby is, you want the baby to cry and things like that.
Let's take Michael from Abuja. Good morning, sir.
Good morning, sir.
Yeah, thank you.
Morning,
We're glad to have you.
Hello.
Yeah, hello, we can hear you. Please go ahead.
So my name is Michael from Abuja.
Thank you very much.
Okay, sir. Like 3 months ago, I started having this shortness of breath, and I couldn't breathe. When I do things, I get tired easily. So I went to general hospital, and they said I have pneumonia, and I've done COVID-19 tests and tuberculosis tests too. But everything came out negative. But right now, when I do things, I started the treatment, but it's not going. and I don't know what to do about it. I've been taking anti-malaria, antibiotic drugs and everything, but it's still just there.
Okay, don't go away yet. How old are you, sir?
I'm 38 years old, sir.
Okay, do you usually have swollen legs?
Sorry, sir?
Do you have swollen legs? Are your legs usually swollen?
No.
Okay.
No, sir.
Okay, thank you very much. I'm sure doctor will have something to tell you.
Okay, thank you very much for calling. I think it's very important that you get seen by a cardiologist. It's very unusual for a young man of 28 to be so breathless and not feel he can do anything. Pneumonia does cause breathlessness, but usually it's very short-lived. So you have pneumonia, you go to the hospital, you get given antibiotics, you get better very quickly, and everything sorts itself out. Now, this sounds like it's been going on for quite some time, and it's still breathless. It's looking very cardiac. So I think you need to see a cardiologist. You need to get an echo scan, which is an ultrasound of the heart, to see how well the heart is pumping. You may be one of those kind of people that maybe has a congenital cardiac defect like we're talking about today, but it's just kind of making itself available, aware in adulthood. So I would think that it would be very important for you to get an ECG and an echocardiogram, and certainly I'm hoping you've already had a chest x-ray. If you haven't had one, then you will need to have that done as well, and just to exclude any cardiac cause for why you're having this issue.
Thank you very much. Now that you have mentioned chest x-ray, ECG, we have Victor from Abuja. We'll come back to my question, sir. Victor, good morning, sir.
Good morning, doctor, and thank you very much for your interesting program.
Thank you very much. We appreciate you too.
Yes, sir. My simple question is that I am undergoing some BP medication,
okay,
and I'm also treating slightly enlarged prostate. So okay. I have some issues, but what is bothering me, my BP is under control, my sugar is under control, but I'm having high pulse rate. So my heart will beat, I can feel it, very, 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 very visible. So is there an issue? I try to check it. It's around 1994. Do I need to bother so much? But my BP is okay, just the pulse rate.
Okay, please don't drop. How old are you, sir?
I'm 52. I'll be 52 by December.
Okay. Thank you very much. Doctor will take it off from there.
Okay. Thank you very much for calling, sir. You said your sugar is, you said you're hypertensive and it's well treated. Are you diabetic as well?
I think he has dropped. He also said he is undergoing treatment for prostate.
For his prostate. Okay, so I mean, as we all get older as men, our prostates tend to cause us a problem. Very important to get that checked to make sure it's not cancerous. Most times it's not, but it needs to be treated. My advice to him would be, obviously, he's doing the right thing in making sure his blood pressure is well treated and is under control. The pulse rate can sometimes be an issue. 90 is still within the normal limit. Normally, say between 60 and 100 is normal, but 90 is towards the higher limit of normal, and you should not normally be aware of the fact that your heart is beating. So my advice to him, well, he needs to go to hospital, get an ECG for them to make sure that his heart rhythm is normal. Maybe he's having atrial fibrillation or a lot of ventricular ectopics or atrial ectopics. All of these things, will reveal itself on an ECG, and if his symptoms of having this sensation of a heart rate is coming now and again, they may fit him with a monitor that he will wear for 24 hours so that they can see exactly what his heart is doing over a 24-hour period, and then they may be able to now suggest, if they find anything wrong, what treatment that he may require.
Thank you very much. Thank you very much. Chief, I'd like to quickly open my phone. Early hours of this morning, I got a call far away from somewhere in the east. Okay. The patient who called is a patient of, the person who called is actually a patient of mine. Okay, so she supplied a BP. She gave me her BP reading. I want to quickly oblige our viewers. The BP reading she sent to me, because I asked her to snap it and send on WhatsApp, she sent me a BP reading of 200/113. That's not all. The pulse was 169. I've never seen a pulse this high since, even right from my med school in Ife till I became a doctor and be practicing for decades now. I have never seen a pulse this high. Okay, so what I simply told her is make your way straight to the hospital.
Straight away, no debates. There's nothing to discuss around this. It's very straightforward. This is
so what could make a pulse go that high?
Well, a number of things. She could be having a heart rhythm problem. I don't know whether she's having chest pain or breathlessness. If she's having a heart attack, it could make the heart rate go so high. If she's in heart failure, it could make the heart rate go so high, especially with that blood pressure. Number one thing is the exact right advice has been given. She needs to go straight. She should be in the hospital right now and being treated immediately.
The early hours of the morning, she sent another one. It had dropped to 122.
Okay, which is still a concern, but hopefully they'll do an ECG and sort it out for her.
Thank you very much. I'm afraid this is how far time can allow us for today's program. We want to appreciate all our viewers, all our callers that made calls from several parts of the country, several parts of places in Nigeria. We want to appreciate Dr. Tosin Majekodumi for coming to. This is a second visit. Thank you so much.
Thank you very much for the invitation.
We'll see you again next week.
Bye-bye, everybody.
Thank you.